Okay, so I'm going to share some cases that were shared with me from one of my former colleagues. Let's look at this case. So this is, I don't have all the history, but this is a patient with Sjögren syndrome and has some lung abnormalities. You can see there's these diffuse central lobular ground glass attenuation nodules. There's a over abnormal esophagus too, retained liquid and debris in there. But the airway, the lungs are abnormal throughout. It's all just sort of the central lobular ground glass nodules. So in the second connective tissue disease, I should also show there's pericardial effusion. I think the patient may have had, I think also had an overlap syndrome. So maybe like a mixed connective tissue disease. But one of the things when we see some of these patients, some of them get some bad pulmonary hypertension. I don't think this patient did, but they can get that central lobular ground glass attenuation nodule. But this patient had previously undergone, I guess, a transbronchial biopsy, and this was all follicular bronchiolitis. And it's interesting because I've only seen a few cases where we've actually gotten tissue, and they're quite variable. I've seen some cases that are more solid nodules. Another case that was large nodules that had been growing over the course of a decade, but it was all just lymphoid hyperplasia. So it probably is a spectrum and depends on where you sample of how a pathologist will interpret it. Whether it's the extent of the lymphoproliferation, but otherwise you'd wonder if this patient was a smoker, if this was HP, but in the setting of connective tissue disease, anytime you see central lobular nodules, I always think about the small airways component. You wonder about chronic aspiration, but they're so diffuse and so clean looking everywhere that I think it's a concordant diagnosis. So follicular bronchiolitis, just as diffuse central lobular nodules, which again, I've not seen that presentation. Let's see. This is kind of a cool case. This is something we've talked about. So this patient, and I've shown some vascular cases recently, this patient has this soft tissue mass in the mediastinum, and you can see there's mass effect and narrowing almost like of the left pulmonary artery there. And I showed two cases last week of young females with pulmonary artery involvement. This also involves the right, but that was more intrinsic to the wall. And both of those patients have a large vessel vasculitis. This patient did have a biopsy, and this is IgG4-related sclerosing disease. And it has been described in several case reports of causing a perivascular involvement and causing vascular narrowing, as in this case. And I guess just the inflammatory cells invade the wall of the vessel, as well as just kind of form a mass around it like that. But you can see this could mimic a large vessel vasculitis, but I think the extensive tissue outside of it should raise a question that there's something more than just intrinsic to the walls. So,
that's interesting. I've seen it involving the aorta like that. I don't think I've seen one so focally doing that to the PA. I mean, that's great.
Yeah, I haven't, but I did look around. There are some case reports of it, so it has been described. And I showed a case a while ago of a mediastinal mass that was IgG4. It wasn't involving the vessels, but I wonder with time if it would have. But
right.
This whole condition, or what spectrum of diseases, never ceases to amaze me, because it seems like every so often we see a new manifestation of it.
Yeah.
Okay. Let's see where I show that. This is a nice congenital heart case here, and so this patient has already gone repair, but this is it's a tetralogy of, it's a D-transposition with a double outlet right ventricle. So if we just kind of get our bearings here, you can see there's the left atrium, the right atrium, and we've got, oops, I just clicked the wrong thing here. There we go. And you can see that this right ventricle is abnormal, and I'll go up and find the vessels here, but this is the aorta, and it's coming off here, sort of overriding the septum there. And so there's the aortic arch, so it's on the right, and then there's you see the crossing vessel, kind of interesting crossing vessel anterior there, descends on the right, and then the pulmonary artery is here, and you can see it's already been repaired, but this comes off anteriorly here, so it's a repaired double outlet right ventricle, and it looks like that RV is pretty unhappy. It's kind of thick and all that, and there's some nice smoke artifact coming in there, and then we see a little bit of compression of this vein here, but it seems to get in there okay. So repaired congenital heart disease case. Let's see what else. Here's another congenital heart disease. This was a 2-year-old who has a, what did he call this? Yeah, a complete AV canal defect. So sometimes those are associated with a trisomy. So in this case, we see the let's see, right date. Oh, I gotta get the right scan. There we go. Here we go. That's the repair one. Here we go. So here you can see the communication here between the two atria, and then there's the defect here as well with the ventricle. So it is a complete AV canal defect there, and you imagine this creates quite a large shunt and has to be repaired rather early, as opposed to just a secundum ASD, which we'd expect to see back in here. So AV canal defect. I don't see many of those because I don't see a lot of kids. Now it looks like this is post repair, I believe. Maybe not. Someone's been in there. Yeah, this is after they repaired it there. So you can see that closed the VSD, and I'm sure what else they did here. And then you got the atria connected to the right place and the correct outflow. So, but yeah, so an AV canal defect. And then last case here. So this is a 43-year-old with, you can see tracheal narrowing and irregularity, and a little bit further out. And if I go to soft tissue windows, you can see there's these calcific nodules along the wall, but also along the posterior aspect. And so this is tracheobronchial amyloidosis, which is a little unusual in that the cases I've seen are a lot more confluent. They look more like this, where it goes all the way around, it's nice and thick. This one had some more skip areas. And it would kind of make me wonder about something else like GPA or something, but the calcium is pretty typical down there as well. So maybe just an earlier manifestation or an earlier time period of this, but typically it's limited to the airways and it doesn't involve anything else. And we talked about this, I think, several weeks ago, where you can use radiation therapy to treat this, at least to try to reduce progression of it. And as I said, we had a few patients here we've treated with radiation, but if I just saw this without any other information, I'd be a little skeptical, just because in my experience, all the amyloid cases I've seen are really diffuse. I've seen a couple ones limited to a bronchus. I've seen an amyloidoma, but sort of sparing the membrane here a little bit and then kind of jumps around would make me at least query something else as well.
Yeah, I would have thought relapsing polychondritis just on the top slices.
Yeah.
And
right.
then, yeah, no, down there it's clearly not. You know, it's interesting. We see those cases where you have a lot of kind of bronchial, more distal bronchial involvement with those kind of nodules that stud the, third, fourth, fifth order airways. I think, and I only seen the 5-6 cases of those. Those I see tend not to have the big air, like the tracheal involvement. Do you?
I've only seen one that went out far and it didn't have tracheal involvement, but
Right. Yeah. Because I have a couple cases where it's just the kind of those, bronchial nodule. The central, the trachea seems to be spared in those, and then you have the ones like this that really involve the trachea and mainstem bronchi, but tend not to go out farther.
Right. Yeah. I don't know why that is.
Yeah, I don't
but I think I've only seen amyloid about 4 times in the airways, and they've all looked the same. I'd say about half the time they're decently calcified, and the other half it's just smooth soft tissue.
Yeah, it's like those parenchymal amyloid calcifications, really chunky, popcorny calcifications, but they're in the wall of the airways. Yeah, absolutely.
So, all right. Does anybody
Santiago Rossi has a couple of. Santiago has a couple of great cases of tracheal, like big nodules of amyloid involving the trachea.
Yeah, I have a bunch too for the tracheal ones. Yeah, but anyways.
All right.
I can go. I have my studies ready.
Thank you, the presenter here.
Here, let me move it here so I know which one it is. Let's see. this one, I think. Share. Let's see, here we go. Okay. Let's see, I just have a bunch of cases. This one is just a nice, nothing super impressive about this. It's just a nice example of, let me get these dates up here, of the various manifestations of, so here's this patient who has, you can see here, little bit of pericardial thickening. This is the earliest scan. I didn't include the soft tissue windows, I apologize, but patient has some pleural thickening, some pericardial thickening, has a very nice classic NSIP pattern of pulmonary fibrosis. And, you know, the guy has a history of lupus, and I know lupus is associated with NSIP. Honestly, I find almost all cases in my experience that have NSIP and are diagnosed with lupus, when they do a really detailed workup, have mixed connective tissue disease. They find some other antibodies that are positive, which this guy did. So he came with the diagnosis of lupus and then left with the diagnosis of mixed connective tissue disease with associated myositis and scleroderma components. He then, this is like 5 days later, has this appearance, and not the best appearance, but bronchoscopically shown to be DAH. So he then developed DAH with hemoptysis and bronchoscopically shown to be in DAH. And then he, a few days later, they treated him steroids, the hemorrhage got better, but then he developed a lupus glomerular, acute lupus glomerulonephritis in-house, and then has the kind of pulmonary edema from the lupus injury. And, they called him scleroderma. I wouldn't call it esophagus really scleroderma at this point, but has a little esophageal dilation. So just within like 2 weeks, numerous manifestations of lupus and kind of mixed connective tissue disease. This case, I don't remember what it is. Let's see. Oh, well, this is a fascinating case. Let's see. So this came to our CTEF conference, and looks like pretty run-of-the-mill CTEF, big PA, big right heart, lungs have all what looks like scarring. Here has, looks like classic CTEF. I mean, you wouldn't ever say it's not CTEF, I think. But what's interesting, he has what I thought, I wasn't sure if this was some form of thickening of the tricuspid valve, but if you see here, he's got this lesion here, and you say, well, is that mixing or is it just a clot? He had a belly study. So here's his belly study, and I think clearly on the belly study, you can see that this is not just a simple clot. If you hold on 1 second, I will pull over his echo. I just want to make sure there's no. So this thing is very lobulated. It's going through the Thebesian valve into the coronary sinus. It's actually also violating and going across the eustachian ridge into the IVC. You can see his IVC is quite dilated, or his hepatic veins. He's got ascites, and they showed me this, and I said, well, it's probably, he's not a drug user. I mean, you can always think of the vegetation, but I thought this was going to be a myxoma. It's very frond-like, very lobulated. Still could be a clot, I guess. Let me just make sure there's no here. I don't see any PHI on this, but I'm always wrong about it. So you can see this thing kind of flopping around in there. Let me show some other pictures where you can see that this thing is not a clot. And where'd that go? Darn it, where'd it go? Sorry. So this thing is definitely not a clot. And you can see it kind of bouncing around, very frond-like. So again, pretty convinced it was going to be a myxoma, and the path came back. It was taken out, not only the path from the mass, but also from multiple. They did a big embolectomy. This came back all as epithelioid hemangioendothelioma. So go figure. So this was a right atrial epithelioid hemangioendothelioma with multiple embolic epithelioid hemangioendotheliomas. So that's pretty interesting, at least in my mind. Maybe you guys see that on a daily basis, but I've never seen that one.
I think Howard showed one of these cases, but I can't remember where it was originating from.
Did he? Okay.
Yeah, but I don't think it was. I can't remember if it was a liver one that had involved the heart. I mean, the lungs, or if it was from somewhere else. But yeah, weird to see those in the chest.
Yeah. This one is just. I don't know what I just did. Sorry. Hopefully this is the right case. I think so. So here is just, it's just a nice, so the point was to show, you know, a nice evolution. So this fatty mass and the showing resin, he was doing the whole, you know, anterior mediastinal mass differential and, you know, it's going into teratoma and some things that wouldn't really even fit for this, but it's a fatty mass. But it has that very nice, I think a lot of us would look at this and say, you know, this is clearly not a typical mass that's got rim calcification. It's kind of along, it has a linear morphology. And then there's also findings of a clamshell median sternotomy. He underwent a transplant. And this was him immediately post-transplant, or couple of days after transplant, where he had this very kind of inflamed anterior mediastinal slash, you know, if you want to call it epicardial fat, I mean, a pericardial fat pad or just a fat pad inflammation that then progressed to fat necrosis. So this is just kind of a nice evolution of fat necrosis over time involving the anterior mediastinum. I just thought it was a cute case. I haven't seen a lot of big chunky anterior mediastinal fat pad necrosis or fat necrosis leading to kind of what looks like a mass.
Death, was that right after the surgery? Was that part of the surgery, or was that remote from the surgery?
It was secondary surgery. He had some infection. He had a lot of inflammatory changes. This was about, I have another CT here. It's not pulling over. But it was all associated with the surgery. So I'm just trying to find the dates here. So this was immediately post-op, I think, or a few weeks post-op. So I'm not sure this wasn't, I mean, there wasn't a sort of a wrap or anything else for a vascular pedicle. There wasn't, that wasn't put there. This was necrosis. Is that what you're asking?
Yeah, so do we think this was from infection then from the surgery or the manipulation?
That's what I would think from the transplant surgery, yeah. That's what I assumed. I didn't see them wrap, you know, pulling in a muscle wrap for improved, you know, blood supply to help with healing. That's what I didn't read that in the history of the surgery. So. Okay.
But was there a documented infection or not?
Of the sternum, there was.
Okay, got it. Thank you.
So there was, yeah, sorry, there was a sternal infection. This one again. Oh, is this the case? I think it is. Yeah. So this is one of those things where just the patient literally just has this anterior mediastinal nodule. And, you know, I see every few years one of these. He has a little bit of surrounding nodes that, you know, definitely makes you think, maybe this could be something else. Let me find the older study. Oh, no, that was the older study. But nothing else really. He really didn't have any other findings on CT in the chest. But the little surrounding lip, you know, normally I would think, oh, this guy's like 50 or 55, I would think, oh, it's just a thymoma. A little bit of enhancing nodularity, but he's missing a kidney, and he had no other mets anywhere else, and this was biopsied and actually resected, and this was a renal cell met, just a solitary renal cell met to the anterior mediastinum. So I think I showed one a while back that was another urothelial cancer, bladder cancer with just an isolated mets to the anterior mediastinum. I don't see many of those, but usually there's just disease everywhere else if you're going to get an anterior mediastinal met, but not in this case. And this is just a cute study because it just shows, and I do want to actually do a study on this because this is like the third time I've seen it happen here, including one that I missed. So here's a patient that has had a coronary CTA, and I cannot get out of this for some reason. And you can see here, I'll just go to but the patient has a pretty trashed proximal RCA, a lot of inflammatory changes surrounding it. And you can see, not a happy looking proximal RCA. Definitely looks like at least a severe stenosis. I don't know if it's hemodynamically significant, but we base so much on just degree of narrowing. Again, this is not a happy looking vessel. And it was read as severe, and that was kind of it, and they sent it to heart flow, and you can see how the vessel gets quite narrow here. And what wasn't picked up was I'll just show it in the recon because it's easier than trying to do it myself. And that was a non-dominant vessel, but what they missed was this, that he was a left dominant patient, and this was a PDA, very focal PDA lesion. And then here is the CT-FFR, where you can see that RCA stenosis is a non-dominant vessel, is not hemodynamically significant, but that very small distal PDA lesion is in fact quite hemodynamically significant. And I now have, I think, 3 cases where, and again, I hate saying this because I don't, and this was actually confirmed on cath, that this was not hemodynamically significant. This was, I'm guessing part of it might have been the fact that this was a non-dominant vessel. But this is the third time I've seen where we have missed the stenosis. I'm guilty of one where there was a complete occlusion of an OM, the ostial occlusion. I just didn't even see it, and then they saw it on the FFRCT, where we've missed the stenosis and it's been picked up and shown to be hemodynamically significant. So just a nice example of 2 anatomically severe stenoses with different significance, at least according to FFRCT, but that case was confirmed. And then lastly, the weirdest case of the day, I've just never seen something like this. This is a guy with a Ewing sarcoma who in the shoulder, and then came in with this lesion, and this was resected and taken out and sent to multiple pathologists who all confirmed that this was a small round blue cell tumor / Ewing sarcoma met, or I guess potentially another primary, but he didn't have this a year before.
Is that so a year before? What is that large vessel going through it?
No, it's a vein. So it's a vein that made
there a year ago.
It wasn't there a year before.
Wow.
So it's this vein that does this loop-de-loop, and it literally just makes a loop-de-loop, connects up, goes out here, and it's just this. I still didn't believe it, and then I looked at the path report, which I don't know if maybe I have it saved. Let's see if I saved it here. And they let's see if this is the path report. Yeah, so they took this thing out, and they confirmed that it was, this identify Ewing sarcoma rearrangements and all this stuff, and it was, they had to still the tissue from his primary, and it was the same vascular rearrangements than his primary, which was in the shoulder. And the reason I saw this case is because he came in about a year later and had a right upper lobe, very different looking nodule, just a simple looking met that they took out, which was also a met. But I've just never seen anything like this before.
So where does that big vein go?
You know what, Dave? I tried to follow this thing for like an hour before I just gave up because it just makes a circle. So it's a circle, comes up and goes up and then connects to another vein. If you follow this thing up, this thing here, that's a vein. goes back in, back to the central vein, and then there's another portion that goes up. But honestly, I just got tired of following
But
these
it does
things.
connect to pulmonary vein.
Yeah, the main thing. Some of these just can go into the mass of the thing and disappear in this tangle. Other portions, like this big portion here, comes back in, and when I was following it back in, reconnects to this pulmonary vein.
Got it. So I think what's happening then is it's got a systemic arterial supply probably. And
it must have some sort of, yeah.
And that's what's propelling so much blood flow that the vein is hugely distended like that.
Yeah, it's just a very, I really couldn't explain this thing. I've never seen a met that does something like that. But all right, those are my cases.
Jeff, I have one.
Okay. Wow, Seth, those were pretty crazy. All right, David, there you go.
So can people see this chest röntgenogram here?
For sure.
Okay, so this person has 90 years old and had some, I think some shortness of breath or something, and has this lowish volume, a little bit of basal atelectasis, maybe some scarring in the lung up here, a bunch of clips, and then these very horrible looking bones in the left shoulder here. And it seems to be all the bones in this region extending from anterior bones like clavicle. Distal part of the clavicle is very thickened and irregular here. The proximal part looks pretty much normal, but distally it gets bad. And then all the bones all the way through to the back, including the scapula on the back of the chest and the humeral head, are looking pretty sad. And here's what some shoulder radiographs from a couple of years ago look like. This is 2019. And you can see that there's this patchy osteopenia through this bone and then this destruction of the shoulder. And doesn't look any better on the other projections. Looks pretty bad. And then we have an earlier radiograph here from, this is 2012, I think. So this is many years ago. At this point, the bones didn't look so bad up here, but we did have this scarring in the lung. So there was a shoulder CT that was done, I think in 2018 or 2019, and they saw this destruction of bones, and they hypothesized that this might be, I think, Milwaukee joint or Milwaukee shoulder or something like that, which we thought maybe that's neuropathic or something, but we looked it up and it turns out it's a CPPD manifestation, calcium pyrophosphate deposition disease. That was the working diagnosis based on a CT from a year or two ago. So I don't know, what do you guys think? It's not normal, I know that much.
Looks more neuropathic, but I'm no bone expert.
Never had radiation with all those clips and whatnot there?
Well, it turns out that in 1984, he had a liposarcoma resected and then radiated. And they gave him 60 centigrade to this region. So it was radiation induced. And you can see that in 2008, he had a CT scan of the shoulder and it showed these little pits of osteopenia. And then the destruction has come up since then. So this is really remote, 25 years ago, radiation therapy with this progressive osteonecrosis. And when I saw the current chest radiograph, the first one I showed you with all of that bone destruction, and it goes through and through from anterior to posterior, you know that this is something that affected that region, and it's through and through radiation that did it. And everything in that path was eventually has crumbled and has been destroyed. So it started out with osteopenia. So about 20 years out, it was osteopenia, and he had at that point, he had lymphedema, probably from obliteration of his lymphatics and things like that. But now it's progressed to radionecrosis. So this is radionecrosis. The situations in which I've seen this, you don't see it very often anymore, where the old-fashioned breast cancer radiation that would be aimed through and through at axillary lymph nodes and then supraclavicular nodes. So you see again this regional bone necrosis involving the bones near the apex of the chest, but all the way from anterior to posterior. That tells you that it's a through and through radiation rather than a conforming radiation field. And so this was osteonecrosis. It was familiar to me because of my familiarity with that old style of radiation for breast cancer, which they don't do anymore. But I think it was not even well known to some of our bone radiologists who have not seen this old-fashioned kind of radiation. So 60 centigrade is a big dose, I'm told, and I think they limit mediastinal radiation to 30 or 40. This is 60. That's quite a bit, and you would expect some effect on bone. So radionecrosis. So nicely done, Travis.
David, do you think it was 60 gray and not centigrade?
Yes, I think it was 60 gray.
Okay, yeah, because that's right. A big. I think for SBRT, I think for standard radiation, it was like 60 gray for lung cancer, and I think for SBRT, it's even higher to a very small area. But that's a pretty big dose to bone.
Yeah.
Now, I don't know about you guys, but I still see sclerosis in the ribs and sometimes the clavicle in patients who get radiation for breast cancer. I don't see a lot of the I guess it's more like an osteitis. I don't see the necrosis or that, but I do see a little bit of sclerosis in those bones. So I think even with the modern techniques and stuff, they still get a little bit of abnormality.
Right. Yeah, and you'll see fractures too.
Well, you can see a little bit of peripheral lung fibrosis. So the ribs that are included in that field might be affected too.
Yeah. Good case.
Okay.
All right.
That's it.
Thank you, David. Travis, you ready?
Sure.
All right.
I've got a few cases prepared here. And this is an interesting recent case from our VA. And this is a man in his 30s, as you can see, and he previously healthy vet who presented with some unilateral weakness, numbness, some ataxia, and some urinary difficulties, and underwent head and C-spine, and well, total spine MR. And you can see on these T2 sagittals that there's abnormal signal intensity throughout the cervical spine, spinal cord up into the medulla. And there's a more discrete lesion here near near C1. And let's see, I'll go to the post contrast and you'll see it's a fairly discrete intramedullary lesion. Now, there were a couple of other small foci of enhancement in the throughout the spine, but they also saw on this that the patient had lymphadenopathy, both supraclavicular and then in the chest, and so they were thinking this was probably a metastasis or maybe lymphoma. You may suspect where we're going with this though, because we're the ones that get to think of this diagnosis. So I was asked to, they did a full PET CT, and there's hypermetabolic lymphadenopathy in the chest. I don't have the PET, but I do have the chest CT. And they brought it to my attention asking, what should be biopsied? There were some lung nodules as well. And if I can find the chest, there it is. And of course, I took a quick look at this and noticed these are very discrete lymph nodes. They're uniform in their enhancement and typical distribution. And then you look at the lungs, and there are a few tiny little micronodules. And so I was the first one to bring up sarcoid as a diagnosis and showed this again to the neuroradiologist, asking, can sarcoid give you this kind of intramedullary lesion? I vaguely remember that from board studying, but it's been a while. And one of our senior neuroradiologists said absolutely. They ended up doing an excisional biopsy of one of these supraclavicular lymph nodes. I think this right cervical or supraclavicular, and it turned out this was all non-caseating granulomas. CSF was negative. He's been on steroids for a while with fairly rapid response. So this is presumed to be neurosarcoid with an intramedullary lesion in addition to what is very typical of sarcoid in the lungs in the mediastinum. So you can see subtle perilymphatic nodules. You know, if these weren't 1.25 millimeter slice thickness, they're old 5 millimeter, you might say these were ground glass, but certainly they're discrete little micronodules. So I thought this was a very interesting, let me see, where's the, I had a different, here, this one. Yeah, this is a case report of intramedullary sarcoid. So they say it's less than 1% neurologic involvement is in the cord, but it tends to be higher up. As you can see, this is similar to the one I showed with fairly diffuse spinal cord edema. So still presumed in the spine, but pretty sure that's what it's going to be given the rest of the findings and his response to steroids. This is a fun one.
So Travis, do you think that this was diagnosable on a chest radiograph with lymphadenopathy being visible, that previous sarcoid case?
Good question. There was no radiograph. You know, this is one of those ones that went straight from, you know, spinal MR to PET and then to CT.
Got it.
But, you know, certainly it looked like it would have been a pretty typical radiograph in a patient in their 30s, sure. And I actually wish I had a radiograph to contrast it with this case. This is a 36-year-old who immigrated to the United States when they were young, has not been seen, you know, until recently in the healthcare system. This is the best radiograph I could find from a couple years ago, and you can see on PA and lateral, this is, you know, big hyla, big left pulmonary artery, and of course this is not lymphadenopathy. These are all vessels. You see there's nothing in the subcarinal space. This is a huge right hilar vascular opacity, huge left pulmonary artery. The right ventricle looks like it's pretty large, left ventricle maybe as well. And so this guy comes in with recurrent hemoptysis. No surprise, he has pulmonary hypertension. But what I think in this case is interesting, you'll see that the cause of this, he had an untreated huge VSD that you can see here as the cause of his pulmonary hypertension with a really large main pulmonary artery, and typical findings, as Jeff mentioned earlier with this case of follicular bronchiolitis, but typical findings that we see with pulmonary arterial hypertension with the little smudgy central lobular ground glass nodules in addition to his areas of hemorrhage. But you can see that there's a little bit of shunting, you know, from right to left across this, and so he does have signs and symptoms of Eisenmenger physiology. But if you had any doubts, and I've shown a case like this before, if you see these and you see the timing bolus, you can diagnose it here too. So we see injection, and you'll see almost immediately after we see pulmonary artery, we see aorta also lighting up before the pulmonary veins. So it's a nice physiologic test here, seeing how the contrast flows. So clearly indicative of a right to left shunt with the contrast getting into the aorta before it's in the pulmonary veins and in the left atrium. So it's one of those nice timing boluses that can show us a little bit of physiology. And then this is just a really quick one. This is a guy that was a lung cancer screening CT, and you know, this is a year and a half ago, or 2 years ago, I guess, relative to now, but relative to his other study. Nothing going on much in the right upper lobe, and then was a little surprised to see this on his lung cancer screening CT with, you know, with a cavity and tree and bud nodules throughout the posterior segment of the right upper lobe. So this is one of those ones where called the clinician, called the techs, and certainly we're worried about tuberculosis in this case. Sounds like he was asymptomatic.
Was he golfing in Arizona?
Was he golfing in Arizona? No. Why do you ask that?
With Coxie.
With Coxie? Yeah.
Yeah. Well, especially if
he
he's
wouldn't have had to be in Arizona. Yeah. But anyway, so he did have one of 3 AFBs that were positive, which scared people even more, but then it finally grew MAC. So this is a case of Mycobacterium avium complex infection, kind of mimicking tuberculosis in a smoker on a lung cancer screening study. So,
And he was truly asymptomatic.
Well, I mean, he attributes his cough to just smoker's cough.
Okay.
So I don't know. I mean, it was hard. I was trying to dig up questions in there, but
so here's a
we
question
try to
for you.
avoid.
So when you're reading these screens and you get one like this, do you call it a lung rad 0 and treat them and bring them back, or do you?
Well, this is a question. I'm curious what everyone thinks. Like, let's just say you have this, right? If you just have a region of consolidation that's new, or you have new central lobular nodules, because we have a lot of debates about this, where I often will call these like, a 2S, whereas some people will call it a 4, a 4A, whenever there's anything that's like, oh, they say it's a nodular area consolidation. Or do you call it a 0? I don't know. I mean, I usually say 2S and then just say it's most likely an airways infection.
Right.
That's my practice. I'm curious what you guys do, because there's a lot of debate. Even in our section, there are people that, will call 4s on all of these.
I only call it a 4 if I think it's probably going to be a lung cancer, and that does not look like lung cancer.
That's not a 4. I mean, you're saying, that's not cancer.
No, I know, and that's but then some people, and it's not
4. Yeah, I don't. That make any sense.
Yeah, I mean, I've talked to like Costa and Sanjeev about this, and there's a lot of debate elsewhere. So I was just curious how others deal with this. So Jeff, would you call this a 2 or a S or a 0?
Well, that's what I was asking. I mean, I would probably call it a 2S and say it's, like you said, probably infection. And they're going to get follow-up, so they're really not going to get back in the screening cycle for some time. It's not like I'm going to say, oh, they're going to get a CT in a year from now. I mean, they're going to get at least chest radiographs or something, because, I mean, that's not an insignificant little infection you got there. But
right.
Yeah. But see, lung rads assumes that you're only dealing with cancer, yes or no or maybe, and it doesn't address other lung findings.
And in fact, I've seen, or I've heard people say that they'd call something like this a 3 and because it would recommend a 6-month follow-up. But I still don't think. I mean, again, it's more of an academic point.
Yeah,
because he's going to get follow-up. But
I just call them and say the guy's got TB or whatever. And get a follow-up in a few months, and we'll come back to the screening at another point. I don't.
Yeah, exactly.
So, Travis, I think this case makes the interesting point that when you first catch MAC, if you catch it early, it's usually in this axillary aspect of the right upper lobe. The classic location that we think about with MAC is the involvement of the middle lobe and the lingula. That's pretty distinctive, but that's actually a late manifestation. The cases I've caught early have usually been in this region, which is right upper lobe, often, halfway out toward the axilla. So this is a classic location for MAC to begin.
So are you saying that, like, let's take an older, thin female patient that ends up with the typical right middle lobe and lingula, do you think they have an initial infection like or do you think they just are colonized? And
no, I think often it starts with this, because I've seen this progress to other location. So it's as if the lesion relatively clears up here sometimes or diminishes, and then it involves those more dependent regions. The infection travels downward with gravity, I think, but I think it's first acquired in this location. So I've seen a number of them early in this region, even in those slender little old ladies. And so I think if you catch it early, it's often in this region. With chronicity, it's more likely to involve those middle lobe and lingular regions.
Well, I wonder, David, I've seen this distribution that Travis showed more often in male patients, particularly those who have a tobacco history, whereas I've seen some very mild
smokers that progresses to like a fibrocavitary.
Right, and it's been described as the classical pattern because it looks like TB. But I've seen plenty of mild cases in older females where it's just in the anterior lungs, and there's no involvement really of the apical lung, and there's no suggestion that there ever was. So
I've seen a number of the little old ladies who are not smokers with this distribution, usually not as severe as this, of course, more of tree and bud sort of thing. So I think part of it is what stage are you? How long has it been there? But inhalational things are usually worse in the right upper lobe in this region. And that's because the right bronchus is the shortest bronchus. If you want to get immediately into lung, you go down, you take the right upper lobe bronchus. And so, even pneumoconiosis, co-workers pneumoconiosis, if you look at the B-Read standards, they show usually worse disease on the right than the left. And I think it's because things that are inhaled go to this region preferentially.
Yeah, I think
including
increased lymphatic drainage in the right upper lobe, and that's why you see more lung cancers on the right than the left.
Well, the right upper lobe is, okay. So it's also, it takes a longer bronchus to get to the left upper lung. So I think part of it is how far do you have to go down the airway and how many particles of carcinogen get filtered out on the way just from that long pathway they have to take before they get to lung. So I think you could explain the lung cancer prevalence in right upper lobe also as a short path and bigger carcinogen particles getting out there.
But you see that with any kind of inhalational disease, even larger particles. I mean, like you said, early silica and coal, even some very mild cases of sarcoid, and you see the earliest emphysema. And if you see like very mild central lobular emphysema, it's often, there's clearly a right dominance. So maybe it's multifactorial, but I think lymphatic drainage plays a lot into that, because that's been consistent across multiple lung cancer registries and studies where you get a significant number more right upper lobe cancers than left. And if you think about it, the left upper lobe is larger than the right upper lobe if you count the lingula. So you would figure that would adjust for any, just there's statistically more lung to be affected. So I don't know.
Well, Jeffy, I think the pathway to get there and the number of particles that settle out in that long pathway, I think has to be taken into account.
I mean, it may be a factor. I just wonder if but I always think the lymphatics probably play a role in it too.
Okay.
We'll never know. All right. Well, I think that's it for this week. So thanks everyone, and I'll talk to you next week.
Thank you.